Yeah, a whole lot like whole body imaging. Typically, you give the patient. Most places would give the patient thyrogen, give 2 days of thyrogen, and then do the study, and then give them the I-131, wait a day or two, and then do the scan. Okay. Notice it says 2 to 7 millicuries. Don't. I would say stay away from infants and pregnant women. Okay. Usually within a day or two, it's going to be back to normal. And then this 8 to 29 millicuries. Typically, the NRC doesn't require any type of hospitalization if you keep the dose below 30 millicuries. You can give, or you can let people go home with more than 30 millicuries if you can show that they're not going to be a radiation hazard to anybody. Okay. But this is a form that they give to patients, and this is something that the state would expect you to have available in your nuclear medicine department. Okay. But going back to our study or story over here. Okay. The TSH levels, this is always good, especially if you're trying to diagnose hypothyroidism, or if you want to make sure you're going to have an effective I-131 body scan or treatment. The TSH levels have to be up higher, as high as you can get them, so that the thyroid cancer will pick up the iodine. Okay. The serum thyroxine, this is your T4. Okay, remember this is the long-acting thyroid hormone. Okay, free thyroxine, this is the one that has been unbound and is ready to be processed by the cells and changed into T3. Okay, so you understand the difference? When the thyroid gland releases thyroid hormone, it's bound to proteins in the blood. And that's where you're measuring that here, the serum thyroxine. The free thyroxine is the unbound T4 that's available to be broken down into T3. Okay? And then the T3, okay, this is the metabolically active form. Usually when the thyroid gland is injured, or especially after radiation therapy, we'll see that the T3 goes up. But if the patient has thyroiditis, sometimes this will be elevated, the T4 will be down, because it's more economical for the thyroid gland to make the metabolically active form. It usually it's a 15-to-1 ratio. You get 15 times more thyroxine than you do T3. Okay? Now, the other thing that's important is how many binding sites are in the blood available to carry the thyroxine, or the hormones, and that's this T3 resin uptake, or T3RU. Okay? And what it's talking about here, are, if it's high, that means that there's a lot of bound hormone. If it's low, that means that it's capable of carrying more hormone than that's available. So it's kind of like, this is kind of like opposite world here. Okay. Now this information it's good to know, because one of the more important calculations is this one right here, what we call the FTI, or the free thyroxine index. And notice that we need to have the T3 resin uptake multiplied by the T4. So this would be the serum thyroxine. Okay. Okay. So I wanted you to be aware of that before we start talking about the parathyroids. Now, everyone's done parathyroids. For some reason, it's really taken off like crazy. In your requisites book on page 102, well, first of all, before we get started with that, okay, remember that typically most people have 4 parathyroids.
Yeah.
They are close to, but not embedded in, the thyroid area. They're usually the superior and inferior poles. And you guys all have the parathyroid handout, right?
Yeah.
Okay. I'm trying to think of what we have here that's important before we get started with this stuff. As I said, normally if you were to do a dissection of a person's neck, you probably wouldn't even know what you were looking at. As I said before, in the good old days when people had goiters, the goiter would make it difficult for people to swallow or breathe, so they would cut the thyroid out. And after the surgery, everything was going fine. The doctor would come back about 2 or 3 days later. The patient was dead. And nobody could figure out why. Until people realized that there were these little green glands located in the neck. So this is an example. Typically, okay, here's the thyroid gland here. They're typically located up here and down here. But they can be anywhere from the mouth all the way down to the sternum, or down into the mediastinum. Okay? So the reason these people were dying is because during the surgery the doctor would accidentally cut out the parathyroids. They didn't know what they were. I mean, they looked like, as I said, little green pieces of chiclet, you know, or chlorophyll that you would see on a piece of gum. So typically what would happen is after about 2 or 3 days, now we said that the parathyroids control what?
Release of parathormone, calcium.
Okay, they release parathormone, which stimulates which cell of the body?
Osteoclast.
Okay, the osteoclasts. Okay, we haven't talked about the skeleton yet, but we did talk about, you know, the skeleton has osteoblasts, which are stimulated by calcitonin, and that causes them to store calcium on the bone. Parathormone stimulates the osteoclasts, which are the ones that nibble away and change the shape of the bone, and that releases calcium into the blood. We all know that calcium is very important for nerve conduction, blood coagulation, and muscle relaxation. The heart especially is prone. The heart actually has calcium channels in the muscle. It's one of the few organs that does, for the ventricles to contract. But what happened is when you take away the parathyroid glands, there's no calcium in the blood, the patient goes into a condition called tetany. Have you ever heard of that before? You know, when people got tetanus, the disease, from stepping on rusty nails, one of the problems that happened is they developed this condition called lockjaw. Because basically all of the muscles would become rigid, and they couldn't breathe, and they would die. Well, the same thing happens with parathyroid, or the lack of calcium. You get lockjaw, you can't breathe anymore, and you die. So it became a very important thing that when we do surgery now, especially for thyroid cancers, we want to make sure that we don't accidentally injure parathyroid glands or the laryngeal nerve or the vocal cords. Okay? So I put down here that there's 2 types of cells in there, what we call the principal cells, which produce the parathormone, and then there's also the oxyphil cells. Okay? And they really, I don't know if they've ever found out exactly what they do, but because all it says here is that they support the principal cells. So, you know, like maybe they give them, cheer them on, you know, make that calcitonin, man, get that parathormone out, yeah, all right. Okay, but anyway, whatever they do, the main ones that we're concerned with are the principal cells. Okay, this was kind of an interesting fact here. You know, you normally have 4, but it says 13% of the population has more than that, up to 13.
Yeah,
Really?
I was surprised, yeah.
You talk about having some hypercalcemia.
Do you think?
Yeah. Well, and in fact, one of the things that gets people into us for parathyroid imaging is they have hypercalcemia, or they have kidney stones that are made of calcium. That's one of the first clues that we look for.
Can you take a couple out?
Huh?
Can you surgically remove some of them?
You know, only if they're a problem. You know, I mean, anything is good so long as it's not a problem. See, if these things are under regulation, it doesn't matter how many you have, because, you know, again, when the calcium levels go up, Now these ones work on what they call positive feedback, because they directly measure the calcium levels, and they're stimulated by that. Then notice it says that 1 to 3% have 3 parathyroids. And so, like we showed you before, on a thyroid gland, we have 2 at the top, 2 at the bottom, 1 on each side. Okay. Now, some of you wonder why, when we do parathyroid imaging, how come we include everything from the mouth all the way down to the mediastinum?
So to make sure there's no ectopic.
Exactly. It doesn't happen very often, but it does happen. So I've got some pictures of it here that shows you that it does happen. The thyroid gland and the parathyroids all start out in your mouth, and then they migrate down to your neck. But as I said, sometimes they don't migrate, they stay in your mouth, and you can have lingual thyroid and lingual parathyroid, or they can travel down too far and wind up in the mediastinum. So that's why it says, so 2% have glands that fail to descend, so they're up above the thyroid, near the pharynx. 2% have them that over-descend, the mediastinum, so down to the thymus gland. So that's why you do the large field of view image first. Now, do any of you switch collimators and go to a pinhole, or you just keep the same one and just magnify it? Yeah. Most places that I know, they change to a pinhole after they do the whole body shot. Okay. I think we talked about the physiology here, so we know that I don't care that it's a 84 amino acid. Just be aware that it regulates calcium by releasing it into the bloodstream. And now we know that calcium is very important. Okay. Oops. Okay, so there's our physiology there. Let's see. Okay. The other thing that you should be aware of, and this is something that can affect the calcium in your blood, is the relationship between calcium and phosphorus. So it's the same thing that we have with sodium and potassium. When one is up, the other is down. So there's always this kind of a battle going on between them. So when the parathyroid glands are releasing calcium, that means the kidneys are going to be excreting phosphates. So this can affect the bones. One of the things that we often see on X-ray are bones that are demineralized on patients that have hyperparathyroidism. And these are some of the different diseases. What I thought was really interesting in our textbook was this little thing down here. Okay, we have the adenoma, which is what we're all typically looking for when we do that. And thank goodness that's 85% of the pathology that we see. Hyperplasia, that's just where the cells get bigger. It's not really like a growth. The cells just sort of get larger rather than, like an adenoma where they're actually multiplying and getting more of them. Does that kind of make sense? You have the same number of cells, it's just that they get bigger. Here you're getting more cells, and they're all normal size. And then the ectopic, less than 5%. And fortunately for us, cancer of the parathyroid is very rare. So, but the problem is that you do get problems with calcium levels. And what we have up here, if you look on this thing here, it says primary hyperparathyroidism, okay, you just have a bad gland. Remember, the gland is out of control. So the negative feedback mechanism isn't working on this, and so it's just producing parathormone without anything, And this other one here is just secondary. And remember, secondary is where the gland itself is not bad, but for some reason, like in this thing here, it says patients with renal insufficiency. Okay, poor renal function, the kidneys are not able to excrete phosphorus, so to compensate, the calcitonin levels go up, the phosphorus levels go up, the body tries to compensate by manufacturing more parathormone. Does that make sense? The kidneys are not excreting phosphorus or phosphates. So because the phosphate levels go up, that causes the parathyroids to release more parathormone. So it's due to bad kidneys, not due to bad parathyroids. And then this one here, tertiary patients that have renal failure. And what happens is, once you lose kidney function, these things just start going out and become, when they say autonomous, they just start, there's no regulation anymore. Okay? So, as I said, normally we find out about it because the patients will be coming in with kidney stones or some other type of, sometimes you'll do a chest x-ray, you'll see that the bones are completely demineralized, or you'll see calcium in the soft tissue. That's what they're saying here. So hyperparathyroidism results in hypercalcemia, so you'll see that on your blood test. I don't know if any of you, when you do your parathyroid scans, do you get the lab tests? Huh? Well, you should get parathormone levels, you should get calcium levels. Those are all very important to have available. Or actually, no, the calcium and phosphorus levels. Because again, if it's renal failure, then that's something completely different. You won't see anything abnormal with the parathyroids if it's renal failure. It says orthopedic complications because of demineralization, so the bones will start fracturing very easily and collapse. And it says cystic bone changes. They get these things called brown lesions. You can actually see these like areas where it looks like the bone has been eaten away. Okay, that's what these brown tumors are. I think I've got a picture of one here that I can show you too. So. Okay, then we just went through all of the different causes with the secondary and the tertiary, but again, here we see this multiple endocrine neoplasia. Okay, we know that this occurs with C-cell cancer. Patients that have C-cell cancer usually have these multiple endocrine neoplasia diseases, which means there's other endocrine glands that have tumors that we just haven't discovered yet. So whenever you see that, and there's also an MEN 2A and 2B. I'm trying to remember, I think the 2A, or no, 2B is the neuroblastomas. And don't quote me on that one. Okay, so remember we have primary, secondary, and tertiary hyperparathyroidism. Okay, so why do we do it? As we told you before, whenever we had to do surgery on the neck, it was a very dangerous, time-consuming procedure. Surgeons would be working on the neck for hours, doing dissections, making sure that they didn't remove parathyroid glands or accidentally, at least the good ones. Okay? And the other, so we do that for removing the one that's the problem, but also the ectopic parathyroids.
How come they don't give patients radiation to shrink it down, and then they do incisions, and less chance of bleeding, less chance of infections and stuff?
It takes a lot of radiation, and you're going to probably do a lot of damage to the surrounding, thyroid and blood vessels and things like that.
But isn't it the chance of cutting the parathyroid is less too?
Well, here's the bad thing about radiation. The thyroid gland is one of these few glands where if you give it external radiation, it's almost guaranteed to become cancerous. Because back in the good old days when we used to, like treat your acne or your tonsils or stuff with radiation, or the thymus gland. Yeah, that's what they used to do. You were like a 5 or 10-year-old kid and you had tonsillitis. Now they used to cut out your tonsils and give you ice cream. At least that's what they used to show you on TV. They didn't tell you how painful it was. But, so somebody got the wise idea of let's treat it with radiation. And so those kids that were irradiated in the 40s and 50s, we wound up treating them for thyroid cancer in the 70s and 80s. because it takes that long for the thyroid cancer to evolve. You know, anytime we expose somebody to radiation, we look at their age. It's like even with mammography. You notice when you're 50 years old, we give you a mammogram every year. That's because when the cancer shows up 30 years later, you've already died of something else. You know, when you have a heart attack or something in your 60s or 70s, that means you didn't live long enough for you to develop breast cancer from radiation. Curious, that's how we look at it. That's how it's looked at. Okay. But this thing here, the first time I did a parathyroid scan, the doctor, I thought he was going to adopt me as his son because they were looking at very long hours of surgery. I wanted to kind of give you some things here of what we used to do. I don't know anybody that does the dual method anymore, but in
It said pallium, right? Or dual?
yeah, this is one of the few that I saw before. This is one that was done by one of our affiliates. But basically, this is the thallium image here. You have the patient lying on the table with their neck immobilized. Let me just see if I get this.
Use
Okay. Yeah, the thallium goes to both the thyroid and the parathyroid glands. So basically the patient would be lying on their back, you'd have their head taped so that they can't move, you lock the table so it doesn't move, you inject the thallium, wait about 15 minutes, and then you get this picture. Okay, then you inject technetium, change the settings on your window to technetium. So now this should just be the thyroid gland by itself. Okay. Then I take this picture minus this picture, and this is the subtracted image. Okay, so there's my parathyroid tumor right there, my parathyroid adenoma. Okay, that's the dual method. The problem is people moved and things like that, and sometimes you would accidentally, if there was a lot of thyroid tissue surrounding the parathyroid adenoma, when you did the subtraction, you would subtract out the parathyroid adenoma. Not very often, but this is a real good one here. Okay. So that's the dual isotope method. If you ever get desperate and you need to do a parathyroid scan, this is one way to do it.
So they say we have 4 images, I see only 3 images up there.
dual isotopes.
Well, the dual isotopes, yeah, this,
On this paper, that method? Let's say you will have 4 images.
What you're not seeing here is that they would do the chest x-ray. I mean, this one they didn't do that on this one. This one is just the subtraction of the neck area. So I don't have the one that shows the mediastinum.
So the thallium is the thyroid and the parathyroid, the technetium is just the thyroid and the
Yeah, so you just subtract one from the other. You have 2 separate frames. So this is frame 1 and this is frame 2. So 1 minus 2 equals 3 over here. Okay. But I mean, that was the first time that I did one, and it came out really nice. Here was this nice big parathyroid adenoma in the inferior right lobe, or next to the inferior right lobe. Like I said, the doctor was able to get that in and out in about 4 hours. Where normally it's about 10 hours. Okay. But this is what everyone is most familiar with. Okay. One of the things that I noticed some hospitals, and this one, okay, so we have, this is a magnified area of the neck. Okay, here's the chin, and here's the, well, the same thing with the marker on it. And then I think they did obliques on this one. I'm not really sure why, but this is an RAO and an LAO. Do you guys do obliques at your place? And then I think this is the
not that.
This is the whole chest area here. I don't see, one of the things I'm kind of concerned with on this is I don't see a time on it. 20 minutes post-injection, and I don't have the delayed images. Because remember, I think with most everybody now, we do 20 minutes post-injection and then 2 hours.
Yeah.
Okay. This is what I'm most familiar with here. Okay. After you do the injection, you do the whole body, or you do the chest and the chin. And then, as I said, normally you're going to see that there's something at the beginning. You can tell this is a fairly recent injection. That's- Huh? Yeah, this is the, here you have the basidic vein coming up, the axillary vein, subclavian, and then going into the heart. And then, this one's a fairly good size adenoma, you know, relatively speaking. But one of the things you really, really have to make sure, and I can't see what they wrote up there, is your time factors.
Initial.
I think this is the delay, yeah.
That's the delay.
So I think that's a delay and that's a delay. But here's the, what's the problem with that, guys?
Which one?
Didn't give a time.
Yeah, for Ashley, what would you consider a problem with this?
All the pictures?
Well, here's my immediate. These are my two immediates, and then these are my delays, according to what they labeled on there. But what's a problem? Or is there a problem?
Didn't give a time.
Does it say the technical bit?
Can't see.
TCO4.
Yeah, this one is probably, does that say, I think it says technetium on it. My eyes are really, really bad. Yeah, so what this is probably just the sesamidian, and this is the technetium to kind of outline the thyroid. Yeah, I mean, that's still, it's kind of a dual isotope method, but it's not your thallium and technetium. Let me just get that telephoto in a little better. Okay, yeah, technetium. Okay, so this is sesamidian, technetium. You guys do technetium with yours? They do this up at Santa Barbara. Okay, so here's just the MIDI, and then this is a good idea to do that. But going back to my original question, what are some things that the technologists could have done to improve that? Ashley?
Well, I don't like how the delay images are on top, but that's just me.
Yeah, I think it'd be better to have the initial ones there, but
Right, because that's confusing unless you know what you're looking at.
yeah. If you had to redo this study a few months later, let's say that you weren't the one that did this one, what would you do? Well, there's a couple of things. Okay, first of all, I don't like the fact that there's no right or left. And second, I don't like the fact that there is no time, like you said. Because if somebody has to reproduce this study, was it done 20 minutes post-injection, 40 minutes post-injection, 10 minutes post-injection? The whole idea of doing any imaging is to make sure you all follow the same protocol. Same thing, okay, so we injected the technetium. Some people will write down, 20 millicuries of MIB, 5 millicuries of technetium, and they'll say, technetium 20 minutes post-injection or something. So in other words, if you have to redo these studies to tell if it's getting worse or better, you need to have that information. Okay, then like you said over here, it would be nice to have a marker, maybe on the suprasternal notch or the xiphoid, because remember we said The parathyroids can be anywhere from up here, here's your salivary glands, all the way from here, all the way down to here, to the heart. So, you know, just an FYI. I know that when you guys get out there, you're gonna do it perfect, right?
We always perfect.
Yeah.
Well, like I said, you need to learn from your people there. Okay. So,